Shall start then. Thank you very much, Brian. The COVID-19 pandemic has had a colossal effect here in the UK and internationally in terms of premature death, short and long-term morbidity, mental health problems, widening inequalities, loneliness and isolation, personal loss, and disruptive economic and social consequences. This has been a dark and difficult year for so many people all over the world. The UK has been severely affected by the pandemic as a result of late and wrong decisions by our government. As a consequence, the UK has one of the worst excess death rates of any country in the world and the worst economic recession of any G7 country. Today, in introducing this conference, I want to focus on a number of ethical issues relating to the coronavirus pandemic, some of which will be covered in greater detail by later speakers. Ethical guidance concerning resource allocation and decision-making, personal protective equipment, moral distress and moral injury, human vaccine challenge studies, ethical issues relating to the timing of the second dose of vaccines, the NHS COVID app, and fairness and justice. I'll be talking mainly from the perspective of doctors, but much of what I say will be equally applicable to other healthcare professionals. The coronavirus pandemic created an urgent need for ethical advice. Doctors have been working under extreme pressure, and many have been diverted into new and unfamiliar areas of work, and find themselves working at or even beyond the ordinary limits of their competence or expertise. Doctors and other healthcare professionals are worried about their ability to provide safe and ethical care, to look after their patients, and worried too about their own health and that of their families and friends. Providing care to existing standards is likely to be difficult when demand is at its highest. With healthcare resources becoming increasingly limited, there have been fears that serious health needs might outstrip capacity and that resource allocation decisions can no longer be made solely on medical grounds. Those fears arose in the first wave of the pandemic and are recurring now as hospitals in London and elsewhere are becoming overwhelmed and as healthcare professionals are stating they are facing decisions about who to treat. Although measures are now in place to increase capacity to accommodate surges in demand, more treatments are available to help treat critical cases, and doctors and healthcare professionals should, in all but exceptional scenarios, be able to provide care using standard protocols and ethical guidance from regulators and professional bodies. There remains the very real possibility that services at times could be overwhelmed. In such circumstances, ethical tensions arise between concern for the health and welfare of individual patients and concern for populations, with decisions about individual need giving way to decisions about how to maximize overall benefit to provide the greatest benefit to the greatest number of people, the utilitarian objective of equitable concern for all, coupled with the need to maintain vital social functions. Prioritization and triage decisions about how to distribute scarce life-saving resources are professionally, emotionally, morally, and ethically challenging. Extreme situations transform, confront, and challenge doctors' everyday moral intuitions. In such circumstances, decision-making needs to be open, transparent, and accountable. Decisions need to be reasonable, based on the best available evidence and defensible moral principles, made collaboratively and consistently, and designed to promote safe, ethical patient care. And given the emotional and moral distress such grave decision-making can cause, it is essential that doctors and other health and social care workers are provided with the support they need and that their well-being is prioritized. The BMA wished to see official national ethical guidance produced at the start of the pandemic and made that case in numerous national fora. The 4 chief medical officers and the medical director of NHS England initially asked Sir Jonathan Montgomery, Helen Stokes Lampard, and Ganesh Sundaralingam to take forward the production of such national advice, and I and others worked with them to that end. However, the government and its decision makers were concerned that some of the necessarily stark messages in any such guidance might increase fear and public alarm and suggest that resources might become overstretched. The government had been reassured that capacity would be adequate, and the Moral and Ethical Advisory Group could not reach a consensus on prioritisation. Accordingly, the BMA was the first organisation to fill the gap and to produce guidance, which was so necessary in order to deliver coherent, consistent and ethical decision-making. Without guidance, there is a risk that decision-making may become inconsistent, irrational and even paralysed. Our guidance was widely covered in broadcast print and online media and in the BMJ, and has influenced both public debate and the guidance produced by other organisations. With the increases in transmission, case numbers and deaths, the new coronavirus variant, and the renewed and severe threats to NHS capacity, we are perhaps now back in a situation where national guidance from governments on a UK-wide basis is again necessary, so that decisions are made consistently and defensively in the interests of patients, the public and healthcare professionals. The BMA's guidance was cognizant of the government's ethical framework produced prior to the 2009 pandemic and revised in 2017, which was designed to help people think through strategic aspects of decision-making during a pandemic, as well as providing an ethical compass for clinicians. It took the form of several guiding principles. Equal respect. Everyone matters and everyone matters equally, but this does not mean that everyone will be treated the same. Respect. Keep people as informed as possible. Give people the chance to express their views on matters that affect them. Respect people's personal choices about care and treatment. Minimize the harm of the pandemic, reduce spread, minimize disruption, learn what works. Fairness. Everyone matters equally. People with an equal chance of benefiting from a resource should have an equal chance of receiving it, although it is not unfair to ask people to wait if they could get the same benefit later. Working together. We need to support each other, take responsibility for our own behaviour, and share information appropriately. Reciprocity. Those who take on increased burdens should be supported in doing so. Keeping things in proportion. Information communicated must be proportionate to the risks. Restrictions on rights must be proportionate to the goals. Flexibility. Plans must be adaptable to changing circumstances. And open and transparent decision-making. Good decisions will be as inclusive, transparent and reasonable as possible. They should be rational, evidence-based, the result of a reasonable process, and practical in the circumstances. The BMA has also taken account of advice from the GMC, which has stated that doctors will need to provide the best service possible within the resources available. It is only if all facilities and equipment that could reasonably be utilised are at capacity that resource allocation decisions between individuals will become inescapable. If demand outstrips the ability to deliver to existing standards, more strictly utilitarian conditions will have to be applied, and decisions about how to meet individual need will give way to decisions about how to maximise overall benefit. The obligation to persevere when faced with an extremely ill patient will be challenged by quantitative decisions based on maximising the overall reduction of mortality and morbidity, and the need to maintain vital social functions. Doctors would be obliged to implement decision-making policies, which means some patients may be denied intensive forms of treatment that they would have received outside a pandemic. Health professionals may be obliged to withdraw treatment from some patients to enable treatment of other patients with a higher survival probability. This may involve withdrawing treatment from an individual who is stable or even slowly improving, but whose objective assessment indicates a significantly worse prognosis than that of another patient who requires the same resource. Although doctors would find these decisions difficult, if there is radically reduced capacity to meet all serious health needs, it is both lawful and ethical for a doctor, following appropriate prioritization policies, to refuse someone potentially life-saving treatment where someone else is expected to benefit from more from the available treatment. Of course, when a decision is made to withhold or withdraw some forms of treatment from patients on the grounds of resource allocation, it is crucial that those patients still receive compassionate and dedicated medical care and attention as far as possible in the circumstances, including appropriate symptom management and, where needed, the best available end-of-life care. These are grave decisions, but the legal principles were established in relation to the allocation of organs for transplantation and have recently been upheld by the Court of Appeal. In relation to adults lacking capacity, these prioritization decisions are not best interest decisions under capacity legislation. The fact that a patient lacks capacity does not import a best interest decision-making model. In short, there is no automatic priority for those who lack capacity, and decisions about their treatment should be made in the same way as for all other patients requiring treatment. If there's a need to limit the availability of intensive care for patients because of the COVID pandemic and a critical shortfall in ICU capacity, it will be unethical to apply those limits differently to patients with or without appointed surrogate decision makers, or those with or without particular religious views. It would also be unethical and potentially unlawful to apply those limits on the basis of criteria that have no clinical bearing on a patient's capacity to benefit from an intervention. All decisions concerning resource allocation must be reasonable in the circumstances, based on the best available clinical data and opinion, based on coherent ethical principles and reasoning, agreed on in advance where practicable, while recognizing that decisions may need to be rapidly revised in changing circumstances, consistent between different professionals as far as possible, communicated openly and transparently, and subject to modification and review as the situation develops. If services are overwhelmed, systems of triage will be required. The rationing or allocation of scarce resources under critical or emergency circumstances, where decisions about who should receive treatment must be made immediately because more individuals have life-threatening conditions than can be treated at once. Triage sorts or grades people according to their needs and the probable outcomes of intervention. It's possible we could reach a point where the decisions made in triage will determine whether potentially large numbers of individuals will receive life-saving treatment or not. It's essential, therefore, that the principles underlying the decisions are systematically applied. In these circumstances, it is likely that priority will ordinarily be given to those whose conditions are the most urgent, the least complex, and who are likely to live the longest, thereby maximizing overall benefit in terms of reduced mortality and morbidity. These decisions must not be based solely on age or disability. Ethically, triage requires identification of clinically relevant facts about individual patients and their likelihood of benefiting from available resources, including potentially a capacity to benefit quickly criterion. Younger patients will not automatically be prioritized over older ones. Additionally, thresholds for granting access to, for example, intensive care or ventilation will have to be changed for all patients with all presenting criteria. By itself, infection with COVID-19 will not guarantee priority. Relevant factors predicting survival include severity of acute illness, presence and severity of clinically relevant comorbidity, and again, where clinically relevant, other factors which may reduce the likelihood of recovery or of surviving complex or demanding treatment. These may include, where directly linked to their clinical ability to benefit from a treatment, the patient's age and any long-term conditions with a direct bearing on their ability to recover quickly. Such decisions must be based on clinical factors related to the outcome and not, for example, on the basis of discriminatory judgments about the value or worth of individual lives. Similarly, health conditions or impairments unrelated to capacity to benefit clinically must not be used to guide decision-making. The presence, for example, of a learning disability would almost certainly not be a clinically relevant factor. Similarly, a simple cut-off policy with regard to age or disability would not only be unethical, but also unlawful, as it would constitute direct discrimination. A healthy 75-year-old cannot lawfully be denied access to treatment on the basis of age. However, older patients with severe respiratory failure secondary to COVID may have a very high chance of dying despite intensive care and consequently have a lower priority for admission to intensive care. Healthcare providers must also be mindful of the duty under equality legislation to make reasonable adjustments to ensure that people with disabilities are able to access and take advantage of public services in a manner as close as reasonably possible to someone without disabilities. Direct discrimination on the basis of any protected characteristic is rightly unlawful, but indirect discrimination will be lawful in the circumstances of a serious pandemic, because it will be a proportionate means of achieving a legitimate aim, namely saving the maximum number of lives by fulfilling the requirement to use limited NHS resources to their best effect. Further ethical questions are likely to arise where the requirements of medical utility have been met, but choices between individuals with equal needs still have to be made. One likely challenge that may arise during the current pandemic is that large numbers of people requiring intensive care are likely to have similar chances of survival and anticipated lengths of stay in ICU. In these circumstances, consideration will have to be given to an egalitarian approach that ensures a fair distribution of resources. The most likely approach in the first instance is a modified queuing system based on the first-come, first-served principle. This would mean that those patients who become critically ill earlier in the pandemic would be more likely to be admitted to intensive care or receive mechanical ventilation than those who become similarly ill at a later stage, albeit that they may only be offered intensive support for a defined but limited period using the concept of a time-limited trial of therapy. While such an approach is procedurally simple to apply and arguably fair, it is not without its challenges. Although perhaps unlikely, it's possible we may reach a stage where decisions about beneficial distribution of resources can no longer be restricted to medical utility alone, and where a modified queuing system is perceived to be insufficient. Given the potential for widespread social and economic disruption, decisions about which groups will have first call on scarce resources may also need to take account of the need to maintain essential services, including health and social care, emergency services, security, essential products and services, including vaccines and healthcare products, critical infrastructure, including utilities, transport and telecommunications, and societal governance, in a situation where the workforce providing those services is severely depleted. This may mean giving some priority to those who are responsible for delivering those services and who have a good chance of recovery in order to get them back into the workforce. In addition to delivering maximum clinical benefit, priorities during a pandemic may include limiting social disruption, ensuring maintenance of healthcare systems, ensuring integrity of social infrastructure, and limiting economic losses. It will be for the government to determine the categories of essential workers and the tests to be applied. This is not a responsibility that should lie with doctors. Should such an extreme eventuality arise, procedures for decision-making must be transparent, reasonable, and based on defensible moral principles, and great care must be taken in clearly communicating the rationale for this approach and the critical importance for all of maintaining these vital services. For responses to a pandemic to be ethically defensible, consideration must be given to procedural ethics and accountability for reasonableness, to ensuring that decisions at all levels are made openly, accountably, transparently by appropriate bodies and with full public participation to the extent possible within the timescale within which decisions will need to be made. There may also be a role for scrutiny of individual decisions by a second doctor, or where appropriate, by properly constituted clinical ethics committees where time permits. Public acceptance of rationing decisions and cooperation in a health emergency are more likely if citizens accept the fairness and legitimacy of allocation decisions and have been informed beforehand of the anticipated response. There are several factors that are likely to influence such acceptance. Where decisions are made clandestinely and without oversight by elected or other appropriate representatives or appointees, confidence in decisions may be lost. Transparent and accountable decision-making processes, including explicit discussion of the ethical principles and reasoning upon which decisions are made, are likely to lead to greater public acceptance. It's also important that the public is kept informed and that there are opportunities for participatory decision-making and deliberative public engagement when feasible, and for public feedback and comment. Doctors who may be anxious about professional civil or criminal liability should be reassured that they are extremely unlikely to be criticised for the care they provide during the pandemic, where decisions are reasonable, based on best evidence, made in accordance with guidance, made as collaboratively as possible, and designed to promote safe and effective patient care as far as possible in the circumstances. During the pandemic, health professionals are likely to be exposed to considerable amounts of stress, may be working well beyond their normal hours, and will be subject to anxiety about their own health and that of their families. In emergency situations, it may also be ethical for health professionals to consider intervening to provide treatment at the limits of or even beyond their competence in order to prevent serious harm. The skills of these professionals may not meet pre-pandemic expected standards of fitness to practice, but they may nevertheless be able to make a vital contribution. And in extreme circumstances, even untrained staff may be required to undertake some functions. Should decisions be called into question at a later day, they will be judged by the facts available at the time of the decision, not with the benefit of hindsight. The GMC has outlined how its guidance applies during the pandemic and has affirmed its commitment to take the circumstances in which decisions are made into account when considering concerns. And additionally, there have been other statements by the health regulators, the CMOs, and the medical directors of GMC and NHS England, giving further reassurance. Health professionals are directly at risk of illness and even death, and those with underlying morbidities may be particularly vulnerable. Obligations on health professionals to accept a degree of risk in providing treatment impose strong reciprocal obligations on employers. All employers have both a legal and ethical responsibility to protect their staff and must ensure that appropriate and adequate personal protective equipment is available and that staff are trained in the use of it. Health staff and other staff essential to the running of health services cannot be expected to expose themselves to unreasonable levels of risk where employers have not provided or have been unable to provide appropriate protective equipment. Where health professionals have a reasonable belief that their protective equipment is insufficient, that it falls short of expected professional standards, they need to raise this as a matter of urgency with their managers. Risk assessments must be based on the specific facts of the case, and consideration should be given to finding alternative ways of providing the care and treatment needed. There are limits to the level of risks to which doctors can reasonably be expected to expose themselves as part of their professional duties. Doctors are not under a binding obligation to provide high-risk services where employers have failed to fulfill at least minimal obligations to provide appropriate safety and protection, and to protect doctors and other health professionals from avoidable risks of serious harm. They can refuse to treat patients if their PPE is inadequate, they are at high risk of infection, and there is no other way of delivering the care. The pandemic and the restricted availability of intensive care will influence other clinical decision-making within the hospital and the community. For example, it will be important for clinicians to review, discuss and document the appropriateness of CPR for all inpatients with and without COVID-associated illness, where there is a possibility of acute deterioration, and for GPs to raise advanced care planning with individual patients as appropriate. Patients need to be able to discuss what will happen to them if they become seriously ill, and to record how they would like to be treated at the end of their life, to share their wishes, beliefs, values and feelings with those close to them and those involved in their care. If patients have sufficient background illness, comorbidity or frailty, that they would not be admitted to intensive care because of the necessary restrictions on admissions, it is important that CPR is not commenced in the event of a collapse. Performing advanced resuscitation for a patient for whom post-resuscitation intensive care cannot be provided would potentially cause harm to the patient, consume limited resources at a time of considerable strain, and potentially put the resuscitation team at unnecessary personal risk. The BMA has produced public-facing materials about advanced care planning during the pandemic. Working as a doctor is inevitably challenging. It involves uncertainty, stress, grave responsibility, workload pressures, competing demands, long hours, and helping patients and their relatives through experiences of pain and suffering, grief and death and dying. All those experiences can cause doctors distress, anxiety, mental illness and post-traumatic stress disorder, as has been graphically reported this week. However, the COVID-19 pandemic is also resulting in moral distress, the psychological harm and disorientation that results when people are forced to make decisions or witness actions that contradict their core moral values. Such issues arise when rationing constraints prevent doctors from meeting patients' needs, for example, when delays to treatment are leading to serious harms. Moral distress arises when there is a dissonance between what professional judgment dictates should be done and what healthcare systems allow. The powerlessness and lack of agency experienced when situations cannot be altered so that professionals can act in accordance with their professional and moral values. Moral distress can cause a perception of moral transgression, guilt, shame, anger, and disgust. And if sustained, it can lead to moral injury, burnout, and enduring psychological trauma. Moral injury is the resulting damage to an individual from a circumstance where moral distress arises, though moral distress does not necessarily lead to moral injury. The pandemic is causing moral distress and moral injury because of the challenges created by a lack of sufficient resources and by measures to reduce transmission. The need for triaging and for rationing, access to ventilation, intensive care and PPE, the need to deprioritize patients with non-COVID problems or COVID patients who are less likely to benefit from intervention than others, denying relatives access to critically ill and dying patients, and having to make harrowing ethical choices. However, the under-resourcing of healthcare means that moral distress and injury are not unique to the COVID pandemic. Permanent underfunding of healthcare risks placing healthcare professionals in unending ethical conflict. Doctors and healthcare professionals need to be educated about the potential risk of moral distress and moral injury. Those experiencing moral distress must learn to recognize it, must understand that they are not at fault, should discuss their feelings, have time to reflect, receive the support and understanding of their colleagues, and have access to appropriate ethical and legal expertise when faced with challenging decisions. The BMA and its Medical Ethics Committee are currently exploring what more can be done both to prevent moral distress and injury arising and to support doctors experiencing those consequences of ethical conflict. Carefully designed COVID-19 vaccine challenge studies may be ethically acceptable. However, it must be recognized that they raise concerns, particularly as knowledge about the virus is relatively limited, which makes it inevitable that information given to trial participants about risks will be incomplete. Nonetheless, it's possible to give informed consent even when the effects of the vaccine challenge study and of infection with the virus are uncertain. Accurate information needs to be given to potential participants about the risks and inconvenience involved. The 8 WHO criteria are essential prerequisites for any vaccine challenge study to be ethically acceptable. Research ethics committees should look closely at the level of financial and non-monetary incentives when scrutinizing the way research participants are recruited in each individual protocol. Payment should not constitute an inducement. Financial incentives should not be at a level which will encourage people to act against their better judgment. The sum paid should be commensurate with the amount of time and inconvenience involved, and payments must never be made for undergoing risk. Given the likelihood that payments for vaccine challenge studies should be substantial, recruiters into trials must be vigilant about minimizing the risk of financial inducements encouraging inappropriate participation. Nonetheless, there's a need to establish appropriate compensation arrangements for individuals and their dependents in the event of long-term harms to or the death of participants. Consent for participation should be separated from the clinical sphere to avoid any pressure or perception of coercion if patients' doctors are involved in the trial. Given that those with comorbidities or risk factors may react differently to the vaccine to those included in the trial, the rollout of any vaccines will need careful consideration and long-term monitoring. In order to ensure public confidence, all stages of the vaccine development program must be collaborative, inclusive, and transparent. Finally, there's a need for independent expert review, including the establishment of a national or independent expert group to decide on whether and how vaccine challenge studies should be taken forward. The decision of the Joint Committee on Vaccination and Immunisation and the 4 chief medical officers to extend the interval between the first and second vaccine doses in order to maximise as quickly as possible the numbers of people protected by the first dose raises both scientific and ethical issues. I don't intend to address the science today beyond stating that in circumstances where there are a limited number of vaccines available to treat at-risk populations, vaccinating double the number of people with a first dose may well provide more overall protection for vulnerable patients against the virus than providing 2 doses for half the at-risk population and no benefit to the other half. However, when consent was taken for administering the first dose of the Pfizer vaccine, it was on the basis that the second dose would be administered some 3 weeks later. Now, if the second dose is to be delayed and administered nearly 12 weeks later, it's been suggested that the initial consent has been invalidated. If one consents to an intervention that's in 2 parts, and the intervention will only be successful or maximally successful if both parts of the intervention are given, then if the second intervention is withheld without one's agreement, ethical and medico-legal questions may well be raised. It could be regarded as some kind of breach of contract, a failure on behalf of the provider to fulfill its obligations. Retrospectively, the change might seem to vitiate or invalidate the initial consent, because in effect one has now no longer agreed to the single intervention or to the rescheduled 2-dose intervention. Although the person seeking consent could not have known it at the time, retrospectively, the person giving consent was making a decision that was subsequently seen to be based on false information. However, the legal view is that no legally enforceable promise has been broken by changing the interval between two doses. It's a principle of public law that public bodies are allowed to change their policies at any time. Uh, Governments have wide discretionary powers, and the policy change in this case is not irrational and would deliver better overall protection for the population. Additionally, the legal view is that an individual patient has no legal recourse against a doctor for failing to deliver the promised second dose at the originally promised time. The doctor's duty of care is constrained by the operation of lawful NHS policies. If those policies limit the availability of medical treatment which the doctor can provide to an individual patient for wider public good, the patient cannot bypass those restrictions by relying on a private law duty of care. On the consent issue, legal opinion states that the change in the dosing policy does not mean that the consent provided for the initial injection is vitiated, because that consent must have been limited to the medical treatment which was provided as the first dose. At the time of the second dose, consent is again required. Given that the potentially significant different efficacy of a single dose of vaccine or of a revised two-dose schedule from the original two-dose schedule, it could be argued that serious harm may come to some patients, including the vulnerable elderly, because of the enforced delay, and that issues of legal liability may arise. Given that the health professionals sought consent in good faith and that the responsibility for failing to deliver the second dose at all or at the previously expected time does not lie with them, it seems unlikely that they will be left carrying the medico-legal can. It would be grossly unfair to extend liability to actions over which the agent cannot have any control. The question still remains as to where patients who thought they had been harmed by failure to provide the second dose would seek to locate liability. Again, the legal view is that it is virtually impossible to contend that a doctor would be liable in negligence in respect of a patient who contracted COVID after the first dose, but before the delayed second dose. There are also ethical issues concerning competing duties to highly vulnerable and elderly individuals and to healthcare and social care workers. However, without those workers being immunised, they will collectively be less able to meet the needs of the vulnerable because staff absences will increase. Additionally, the more second doses that are administered, the fewer first doses will have been given, potentially leaving large numbers of health and social care workers, the vulnerable and the elderly, unprotected. We need to be advocating for the protection both of health and social care workers and of the vulnerable, while emphasising that maximising the protection of healthcare workers itself helps to protect the NHS and to facilitate its response to the pandemic. I'm going to skip over what I was going to say about the COVID app. As time is short, I'm already overrunning, and you'll hear a detailed presentation about the app later this morning. So I'll now come on to the very final section about justice and fairness. The pandemic has starkly revealed health, economic and social injustices and inequalities that preceded the onset of the COVID infection. Some groups have faced far greater risks in the pandemic: BAME populations, those who live with poverty or job insecurity, those who are elderly. The current virus seems able to exploit almost every dimension of pre-existing disadvantage, what Amartya Sen calls antecedent inequality. This underlines the injustice and unfairness in the activity of the virus, which so clearly reflects the polarizing structural injustice and unfairness within our society. Health justice is inseparable from social justice. The UK Clinical Ethics Network defines justice as distributing benefits, risks and costs fairly, the notion that patients in similar positions should be treated in a similar manner. This links back to an Aristotelian approach in which equals should be treated equally and unequals unequally in proportion to the relevant inequalities. As Amartya Sen rightly says, Equal consideration for all may demand very unequal treatment in favour of the disadvantaged. The pandemic is unleashing 4 waves of health and wider problems. Those resulting from COVID itself, those from urgent non-COVID conditions, those caused by interrupted care and screening programs, and the wider impact on socioeconomic hardship and societal health and well-being, including on mental health and on intergenerational injustice, including educational injustice and injury. Issues that have been particularly pertinent in respect of self-isolation during the pandemic include the lack of financial support for those isolating and the woeful, shamefully low levels of sick pay in the UK. We need to consider the scope and extent of our duties of justice, duties to individual patients, for populations and for other populations beyond the UK, particularly in respect of providing vaccines to low and middle income countries, intergenerational justice, justice to future generations, to protecting the natural world and the land, and to addressing climate change. Finally, part of our commitment to justice and fairness will involve advocacy for a public inquiry into the grievous errors that have occurred in handling the pandemic, which have led to tens of thousands of unnecessary and premature deaths. If we tolerate impunity for what has happened, we undermine trust in democracy, governance, and justice, and the social solidarity and mutuality that bind us together. So I will conclude by stating that the pandemic should reinforce our moral duty to act as advocates for individual patients, our responsibility for public health, and our moral duty to speak out individually and collectively, informed by our commitment to medical ethics and human rights. Thank you, Brian.
Right, thank you very much indeed. That was a superb overview, John, and precisely what I've been asking you to do. You've set out the principles very clearly. You've provided a sound framework. You've placed this in context. I was delighted to see the emphasis on inequalities. Although we can know that they're there, this focus that has been provided is a very important one and helps us to remind ourselves about that. I want to go straight into breakout rooms now, and these are going to be completely self-managed. We are not asking for any feedback. You will be randomly assigned to a breakout room. These are completely self-managed. It would be good if you just introduce yourselves to one another, perhaps talk about your hopes and expectations for this day conference and any questions that are beginning to arise for you. You will have an opportunity to be in those breakout rooms later on as well, and there is also time for a comfort break. So you've got to get quite a bit in between now and 11 o'clock when Emma Nottingham will take over chairing the session. John, thank you very much indeed. I think it's far too cheesy to hit those clap function things at the bottom as a response. I think you can take them as read. Thank you.
Thank you, Brian. Thanks.